Dr. Giraldo, as a cardiologist, could you describe how poorly controlled diabetes affect the heart?
I guess in general, when cardiologists look at the heart, we kind of look at everything, so the cardiovascular system. And so we look at the general population versus diabetics. So compared to non-diabetic, diabetics have a lot more prevalence of coronary heart disease. So whether that's coronary artery disease or that same process kind of throughout the body and all vascular beds. And, we'll touch on the different beds as we go down the long. Basically, every artery in the body feeds some organ. And so it's a multi-organ system disease. So the patients with diabetes are more likely, up to about 20% of them can have what we call silent ischemia. So you're doing a stress test and the stress test is abnormal and you may not feel anything. What we do with that information, that's enough for a whole lecture in and of itself. But there is evidence that up to 20% of people may have these complications and they don't even feel it. So it all kind of depends on the A1C, but men, for example, that compared to non-diabetics are about twice as likely to have multivessel coronary artery disease. Females, the risk is tripled. And this is independent of all the other risk factors that we typically look at. So on all comers that came to the cath lab with chest pain, depending on what their A1C was, if it was 6.7, 8, 8.8, or 10.4, the likelihood of finding multivessel coronary artery disease went up kind of by each of those quartiles. If you have an A1C of 10.4, the likelihood that you had 3 or 4 vessel disease was significant. What we know in terms of these complications is we can have an impact to a degree. So treating the diabetes in type 1 diabetics can help prevent some of what we call macrovascular disease in the arteries. So if you have a blockage and you're controlling the type 1 diabetes, that may help with the blockage. We don't know that for the type 2 diabetics. Well, what we do know is we don't have any objective evidence that controlling them will prevent the big blockages from coming, but it does help with the microscopic blockages. So I don't know if you guys have ever been to the museums where you see the human body and it's like a sponge, right? So the vascular supply is really, we see the big pipes, but it's truly like a sponge. And so the little distal tips of the sponge kind of start getting eaten up throughout the body. The biggest complication that we deal with is acute heart attacks, so STEMIs. Non-STEMIs are also heart attacks. Their mortality is higher than the big sudden heart attacks.
And if you have a patient who has diabetes, what test do you usually do to evaluate the severity of that has much affected the heart?
In general, there's 2 different options. One is, not 2 different options, but 2 different combined strategies. One is the medical therapy, which nowadays is pretty robust. So, we need aspirin, we need cholesterol control, we need blood pressure control to less than 130/80. And, that's important, especially so we keep him happy. We also need to look at, besides medical therapy, is there a blocked artery that we need to fix? And do we need to, so we'll go in usually through the wrist, take pictures of the heart arteries in the setting of an acute heart attack or a highly abnormal stress test and symptoms and say, okay, well, is there a blockage? Do we need to fix it? So, we can put a stent and take care of that. In the acute heart attack setting, that does have an impact on mortality. And so it's important to identify that and kind of treat it. And, we always like to take care of that and it's rewarding, but it's better if we can kind of prevent all that from getting there in the first place. So.